So supportive or against? Evidence-based medicine.
Supportive.
Supportive. Patient-centered care.
Supportive, depending on how you define it.
Supportive. Yeah. Medical assistance in dying.
Against.
Against. Okay. Supportive. Contraception, like condoms and birth control.
Supportive in the right context.
Okay. Yeah, we'll dive into that. I'm supportive. Elective abortion.
Against.
Against. Okay. Supportive. Gender-affirming care for adults, whether that's medical or surgical transgenderism.
I can't give a one-word answer on that. I really care about the people that are caught in that, but I have a hard time supporting something that I don't think is addressing the underlying issue.
I will say, in general, supportive.
Okay.
Okay. Do you think that a doctor's religion affects their medical decisions for the patients that they are treating? Yes or no?
I think a doctor's core beliefs affect that, so yes.
Yeah, I agree. Yes, I do believe that. Do you think that it's okay if it does?
I don't see how it can't.
Okay, but I guess the question is whether you think it is okay for someone to impose their own, I guess, religious beliefs and the moral compass that they have derived from it onto patients that don't necessarily share the same religion as them. Thanks so much for joining me on the podcast. I've been wanting to do a podcast talking about faith, religion, and personal beliefs and how that shapes doctors' care for patients. And one thing that I want to say before we even start the podcast is that the point of this podcast and discussion is not to debate whether or not God is real, or really to kind of argue whether the way that you practice or I practice is correct or not. But really, it's really to explore how these personal beliefs shape patient care when you're face-to-face with a patient. I personally feel that so many topics around healthcare have become so polarized in the recent years, and this forces people to separate into separate silos and leads to things like identity politics and groupthink. And I think that this is one of the biggest modern tragedies. So, I know that you and I are coming from different perspectives, and I really do appreciate that you were willing to sit down with me, because honestly, when I was searching for people and reaching out to people to speak with me on some of these things, a lot of people are either not brave enough or not stupid enough as you and me to actually talk about this in a public forum, so thank you. And one thing that I'll say to anyone that's watching or listening to this is, please watch and listen with an open mind. If what we say does not totally align with your personal beliefs, please don't demonize us. This is really supposed to be an open conversation, and a constructive one for that matter.
I totally agree. I think the world is a better place if we listen to each other and understand where the other person is coming from, understand some of the wounds that they may have from the past. But one of the things that is the top of the list for marriage counseling is always to put the best spin on things. So always expect the best interpretation of what's been said. So I think we did that when we had a telephone conversation.
Absolutely.
And I hope that we can do that. And I hope that your listeners or your watchers will be able to have that same idea, that maybe either of us doesn't express things in the way that they can hear the best, but that we are not intending to be inflammatory or to disrespectful in any way.
Absolutely. So on that note, Dr. Margaret Cottle, please introduce yourself, maybe talk about what you have done in your medical career and what your involvement is in the Christian faith.
I graduated from the University of BC in 1978, before most of your watchers were probably born. So I've been involved in medicine for over 50 years. And I was drawn to medicine partly because of my Christian faith and through lots of experiences that came through that. But because I really, like most of us who are in medicine, really wanted to help people. And I felt that there was a very holistic part of medicine where we were able to help physical needs as well as spiritual and emotional needs as well. And when I was in medical school, there was no such thing as palliative care. The big textbook of pain didn't even, the big textbook of cancer that's about this thick didn't have a single entry in the index for pain. So it was a new concept when I was about 10 years out of medical school. I attended a morning conference in Halifax when my husband was doing his residency that was included 4 of the original bright light people from the palliative care world. And I came home just stunned because I felt that this was an area of medicine that took into consideration all those things that I had loved about medicine for so many years. When I would start to talk to my preceptors about, wow, this person had been in a concentration camp in World War II, and they'd roll their eyes and they'd say, well, what's the blood pressure? And I finally found a discipline within medicine that was interested in people's stories, interested in who they were, and understood the power of that narrative in their life. And so I never looked back. I ended up doing what was available then, which was 4 weeks of training in Montreal with Dr. Balfour Mount and his team. I came back to Nova Scotia. I had little kids. My dad, who had lost his wife to cancer a few years before, came to Nova Scotia and was the mom for our children while my husband was in residency. And I came home from my 4 weeks of training and was on call the first weekend. Yeah. So it was trial by fire, but there was so much about it that really just fed something important in me as well, that there were people who were fearful, and I was able to come into their lives and say, I'm here. I can come alongside you. There were people who were in pain, and I knew how to help that. There were families who were in kind of disarray, and I knew how to help them come together. And that was a really beautiful thing in my life. And we moved back to BC after my husband's residency, and I've been involved in all aspects of palliative care, home care, care on the palliative care unit, care on the consult team, all those sorts of things, and teaching. And I really have enjoyed the home care the most. I think partly because I'm kind of a nosy person, and I love going into people's homes and seeing a picture. Oh, this is when I met the Aga Khan. Like, whoa, this is interesting. Or pictures of where they came from and stories that they can tell me. And I still, I think, cause some of the home care nurses to roll their eyes because when I do a home visit, it usually takes longer than somebody else because I'm so interested in their lives and in what's going on. But I have found in my practice that time is never wasted. Yeah. You know, you make those connections with people and they come back to you and they feel like they can trust you and that you understand them, and then you can determine a course of where to go from here together. And anytime that you can do that collaboratively, it's always going to be better.
Yeah, I mean, so much of what you just said resonates so deeply with me. Just taking the time to hear someone's life story, hear their values, and just develop a basic connection on a human-to-human level just goes such a long way in terms of patient-physician trust. And I think just even the overall fulfillment that you get from your job as a physician, right? We're not there to treat patient with chest pain or girl with gastroenteritis. We're there to treat the human that's in front of us, not only the biological portion, but the biopsychosocial portion of them, right? So that's wonderful.
Well, I also think that in palliative care, Dr. Cicely Saunders, who's the founder of modern palliative care, she was from the UK, and she talked about total pain and how there's it's sort of an overlapping Venn diagram. There's physical pain, there's spiritual pain, there's psychological pain, and there's social pain or familial pain. And one of my colleagues actually says there's such a thing as bureaucratic pain too, which
I believe it.
Which, you know, people, we laugh and say in the U.S., well, they have all these different insurance and all these things to deal with. But here in Canada, we have bad bureaucratic pain too. Yeah. If somebody has a cancer biopsy that's positive, and they wait 6 weeks before they can get an MRI, and then they wait another 3 weeks before they get the results of that. That's bureaucratic pain. So I think we have that everywhere. But that sense of people being whole people is so important, and that has a real overlap or congruence with my Christian faith. When, from my understanding of the Bible, my understanding of who Jesus was as a person and how he treated people around him, every person is made in the image of God. Every person is worthwhile. Every person deserves my respect, deserves all the expertise that I can bring to them. Have I always done that well? No, I haven't. My mentor, Dr. Mount, always loved the Martin Buber's thing with the I-thou relationship, that idea of really connecting with people. And if you look at the person of Jesus, he did that. You know, he met the woman at the well who he should never even have been talking to, and he connected with her. He knew all about her, and he invited her to serve him. So there are things like that are the North Star for me in how I treat my patients, how I treat my colleagues, and I guess the standard that I would measure myself against, not whether I'm better than the other doctors or whether I'm better than something that the media feels is a good doctor, but how Christ-like am I in how I do that? Yes, I was very open about my Christian faith, and we have the student group of the Christian Medical and Dental Society of Canada. They've met in our home now for over 30 years. We've served weekly meals to them for 30 years and invited people to come. And you don't have to be a Christian to come or anything. We had a Sikh young man who came for a year. We had a couple who were Ishmaeli who came for a couple of years. So it's very open and welcoming, and we talk about lots of different things. But I was very clear that each one of us has a set of core beliefs. And those core beliefs are important in how we treat other patients.
Absolutely.
How we treat our patients, how we treat our colleagues. I would say to them, if you don't have an understanding about what those core beliefs are for you, what are the things that you, quote, won't tolerate? You can be too tolerant about something. So what are the things you won't tolerate? What are the things that are most important to you? And understand how those core beliefs are going to affect how you treat your patients, how you treat your world, how you treat your colleagues, and how you treat the other workers who are in the healthcare system with you. I've given lots of talks to my Christian colleagues as well about this, and I said, look, I'm very, very strict about this. If you have a messed up idea about why suffering happens, you're going to be dangerous to your patients and their families.
Well, everything that you're saying just really, really resonates with me. I love what you were saying about having that North Star, like a moral compass. And pretty much that is like the entirety of what I want to talk about today. So it's really great that you're bringing that up unprompted. That's lovely. I have a few things that I want to talk about because, as you can tell, I've thought about, I guess, faith and personal beliefs and how it applies to medicine and the care that we provide to patients quite a bit. And you know that I've talked about some of these issues. But I was thinking maybe to introduce some of the topics, we'll just go through the list of topics saying one word, whether you and I are supportive or against it. And then after we go through this list, we'll just dive into each one and we can elaborate a little bit more. Is that okay?
Sure.
Okay. So supportive or against? Evidence-based medicine.
Supportive.
Supportive. Patient-centered care.
Supportive, depending on how you define it.
Supportive, yeah. Well, we can talk about that. Medical assistance in dying.
Against.
Against, okay. Supportive. Contraception, like condoms and birth control.
Supportive in the right context.
Okay, yeah, we'll dive into that. I'm supportive. Elective abortion.
Against.
Against, okay. Supportive. Gender-affirming care for adults, whether that's medical or surgical transgenderism.
I can't give a one-word answer on that.
Okay. kind of maybe is that?
This one's a really hard one for me because, going back to the evidence-based medicine, I don't see really any evidence that it's been helpful for the dysphoria that they
Gender
have,
dysphoria?
the
Okay,
gender
yeah,
dysphoria
okay.
that people have.
We can dive into some of the details.
So
We'll say
it's
maybe.
hard for me. I would say that I really care about the people that are caught in that, but I have a hard time supporting something that I don't think is addressing the underlying issue.
Okay.
So that's where I am.
Okay.
Sorry, I know it's not one word, but I can't
No
really
worries.
do that.
I will say, in general, supportive.
Okay.
Okay. Do you think that a doctor's religion affects their medical decisions for the patients that they are treating? Yes or no?
I think a doctor's core beliefs affect that, so yes.
Yeah, I agree. Yes, I do believe that. Do you think that it's okay if it does?
I don't see how it can't.
Okay, but I guess the question is whether you think it is okay for someone to impose their own, I guess, religious beliefs and the moral compass that they have derived from it onto patients that don't necessarily share the same religion as them.
I think that's a different issue than what you are saying. I think every single person has that moral compass of their own, and whether they believe it or not, or recognize it or not, they are imposing that on the patient that comes to them.
Lovely. I
And
love
so
that. I love that response.
there's no way not to.
Yeah.
I mean, you are who you are.
Yeah, absolutely. I totally agree with that.
On the other hand, if you're being controlling about it, that's not okay.
Yeah. Okay. Why don't we just dive right into it?
Okay.
Why don't we start with evidence-based medicine? Because this is how you and I got connected, right? I
Yeah.
posted a story of how this really was kind of the core of why I left my Christian faith. So maybe before I even we get into it, maybe I'll just share my story. So I grew up in a Christian household. I went to a Presbyterian church growing up. And, I grew up as a Christian. I accepted Jesus Christ as my Lord and Savior. And I don't think I was the most quote unquote hardcore Christian growing up, especially in high school and even in my first couple of years of college or undergraduate. I was really into partying and drinking, smoked weed in high school and stuff like that, right? So yeah, I guess you can I was kind of like a loosey-goosey hippie type of Christian, okay? But when I was in second or third year of undergraduate, I started going to a church that was, I guess, much more evangelical. I think the actual denomination was Southern Baptist, okay? And they had a very, very charismatic pastor who was an excellent speaker. Going to church on Sundays really felt like I was going to a lecture, and they would even hand out pamphlets where you can write down notes and stuff like that. And that I felt like that was actually quite psychologically stimulating for me, and I really enjoyed it. I became more and more immersed in the Christian faith. I was going to Bible studies on Wednesdays, going to morning prayers on Saturdays. I was leading a men's small group. I was, at one point I took a course on how to evangelize and was going to, college campuses with some of my church peers and evangelizing to people on campus, and I can wholeheartedly say I really did believe Jesus Christ was my Lord and Savior, and I was ready to die for my faith at that point, and live for my faith for that matter, right? I think things really changed when I went to medical school. Because I think in college, you can really surround yourselves with who you want, people that, subscribe to the same belief systems as you, people that look like you, talk like you, and when I went to medical school, you're thrown into a pool, the one classroom with a bunch of really, really intelligent people from many different ethnic backgrounds, religious backgrounds, cultural backgrounds. And I felt like a lot of the narratives that I was taught through my Christian faith were kind of being broken down as I was going through medical school. One of the things was like talking about how people from other religions don't have like the best theology or their narrative, Jesus Christ as a person and him as a deity was not totally accurate. Like oftentimes it's kind of like Catholics are not as following the Bible as closely as Christians, or Jewish people, they've rejected Jesus Christ, and those were the Pharisees that were the ones that actually pinned him to the cross, so and so forth, right? So, when I was in this classroom with all these different people, I'm like, man, these people are really smart, and they're really, really nice people, like genuinely people that I loved, And I think that was the first time when I was like, okay, like, I think I need to like actually go back to the drawing board and actually determine if this is like really what I want to subscribe my life to. But, I continued going to church straight through medical school. And when I went to residency, that's when you're really taught how to critically appraise the different research and information that's out there in the sphere, right? So, you're taught if you ever read a research paper, you need to critically appraise the information that's in there. How was the information gathered? How was the population that was in the study? How were they selected to be in that study? Are they applicable to the patients that you're actually treating? Mm-hmm. What was the intervention? What was the control? Was the study blinded? And what were the outcomes? Specifically, like what's the number needed to treat, number needed to harm? Was there statistical significance? What's the confidence interval? And based on all of these different things, you're analyzing whether or not the information in that study is actually applicable to your own practice, and whether you would want to apply it in your own life, and whether you would actually want to change your practice and use the information to treat your patients, right? And that was like a true, I guess, like a shift in my mentality where like you're using this hyper logical way of thinking to really determine how you're going to act and think. And when I went back to my Christian faith, I really felt like there was a lot of circular argument. Like I think the thing that I kept coming back to was, God is real because the Bible says so. God thinks that homosexuality is a sin or it's bad. Why do we believe that the Bible is correct? Well, because the Bible is the Word of God, and therefore we just keep entering this circle. And it doesn't have to be about homosexuality, but it can be about whatever it is, Yeah. And so that was the big breakdown in my mentality where I finally said, like I'm not totally sure that I can actually keep subscribing to the Christian faith because, this hyperlogical way of thinking in medicine just doesn't seem possible to coexist with faith. And so that's kind of my story of like my Christian faith and why I left it. What are your thoughts on that?
Well, I mean, it's your story. So, you know what I mean? I'm not here to criticize your story or to say you were wrong or anything like that.
Yeah.
All I can say is that if there have been many people throughout history who have looked at the evidence. Okay, they've looked at the biblical evidence. They've looked at the extra biblical evidence, the historical evidence. They've looked at the evidence of the change that's happened in people's lives when they become believers. And they have they've looked at the 400 prophecies from the Old Testament that were all fulfilled in Jesus, that were written before he was born. They looked at how all of the disciples who were, they ran away from him, but then after the resurrection, every single one of them went to his grave without giving up on that. And they just said, if it had been a big conspiracy, that they had no reason to hang on to this if it had been a conspiracy for all the things that they were against. So this idea that somehow it's all circular, I guess I would disagree with that. And there have been a lot of people through history who have sat down and said, I'm going to prove this wrong, and ended up becoming believers when they see all these extra things that have come along. The most recent one that has sort of been out there,
Case for Christ, Lee Strobel.
It is Lee Strobel, and one of the people that Lee Strobel interviewed for his book is a good friend of ours. So Dr. Edwin Yamauchi, who has done a lot of work on the original, he wrote a book called The Stones and the Scripture. So it's the archaeological evidence that Lee Strobel talked to him about, and all of these different things that are there. So I don't think one has to throw the scientific method out in order to do that and have it be, there is still a lot of evidence that is there, I would say. And
Totally.
There's even a book called Evidence That Demands a Verdict that it talks about this.
Totally. And I guess I'm not really debating whether or not Jesus Christ as a person was real or not, or whether he was, because if I'm being honest, I actually think Jesus Christ was a real person. Do I believe Jesus Christ is, the Son of God and the way, the truth, and the life, the only way to get to heaven? I'm not totally convinced. Do I believe that there is some kind of deity that kind of guides the universe? It's possible. And just like you said, I'm not discounting faith at all. I think faith faith is incredibly powerful, and I've seen it myself. Like people that are suffering, they can find real hope and meaning from their faith, and I think that's incredibly powerful. That's something that science can't even explains, and something that science really can't even offer, really, when someone is in that kind of intense suffering, to provide them with that kind of hope and meaning, right? But I guess the way that you practice your Christian faith, I just feel like it's very counterintuitive to logical thinking in the way that we practice medicine, looking at specific numbers and dissecting p-values and stuff like that,
Well, maybe on the surface.
You think so?
Maybe on the surface it looks like that. But you know what? The most powerful thing we do in medicine is to relate to other people, is to come alongside them and say, I see you. I know that this is a dark time for you. I'm going to be here, and I'm going to be here, and I'm going to get this nausea. I'm going to make sure that you don't have it. I'm going to make sure you don't feel breathless anymore. I'm not leaving this place until you feel better.
Yep.
And that's way more powerful than the oxygen that you're giving. So this idea that somehow these things don't come together, there's so much in medicine. Haven't you ever had a patient? I have had many, where you see all the numbers, everything looks great, and something says something's not right about this patient. Okay.
The vibes.
Yes.
You can't put your finger on it, but there's something off.
You know there's something wrong, and the more you go in medicine, the more you trust those things.
The sixth sense, that's something that we always talk about in medicine.
So where is that in the evidence-based medicine?
Yeah. But, at this, this really does kind of make me think about that other case that I recently talked about on social media, where I had a patient who had a really bad traumatic brain injury, who is no longer really cognizant of what he's doing, and he's masturbating in front of nurses, and he's doing all these really inappropriate things, being super nasty and mean to his wife, and it's how do you put your finger on that? How do you make any sense of that at all? It just, that same argument, I feel goes in the other direction as well, right? Cuts both ways.
I don't try to make sense of things that are tragedies. I mean, we had a psychiatry prof who said, one of the things that we do in medicine is we try to say everything's a problem. But a problem means you can solve it. There are some things that are just tragedies. So we had a friend in Nova Scotia who, when she was a child, had been playing on a train track in Prince Edward Island and had been run over, and she didn't have, her legs were gone. Now, she raised 4 children and she had artificial limbs and everything, but she didn't have a problem because her legs were, she had a tragedy. The problem was, how was she going to walk?
Yeah.
Okay. And so this idea, I think sometimes people come to us with a tragedy in their lives, and and we say, okay, we're going to try to solve it like a problem. Okay, so I would say, for me, seeing a person like that, and I've seen a number of them, I can tell you.
Yeah,
You know,
100%.
people get delirious at the end of life, and
I think it's way more common than people think it is.
oh
actually.
yeah, it is, and we've got lots more that we can do now to help them. So it's not so desperate, and I think with Precedex and some of those things, we're going to do better too,
Okay.
you know, coming up. But anyway, I would say that what we have there is something that's really tragic, that we live in a world where tragedies happen. The fact that how I believe about Jesus or how I believe in the Bible's full of tragedies. You know, it's full of things where people made horrible decisions. And that's part of the reason I believe it, because it's not sugar-coated at all. I mean, people are real. Even the greatest king in the Old Testament, David, did a whole bunch of horrible things. So, you know, it's not like it was all cleaned up and here we've got this nice little social media Bible. It's there, and some of it's pretty awful. And yet, you know, that's the world Jesus came into, became one of us, all of those sorts of things in terms of my beliefs. So what that means to me is that when I see this man, I don't see a problem. I just see it's tragic. You know, here's a man who probably was a decent guy before in his life, and now this is the way he's left. He's trapped into this, and now it's our privilege, really, to, sorry.
That's okay.
It's touching my microphone here. It's our privilege to step up to the plate and care for this man and care for his family. Okay, so his poor little wife is not left dealing with him alone.
Yeah.
And we don't do that. Our culture does not do that.
Yeah.
And what we do is we're more interested in our own comfort and our own entertainment, and we pay people huge amounts of money to chase a puck around the ice.
Yeah.
I'm not opposed to hockey, but that's where we're spending our money instead of supporting healthcare workers who could come in and give this woman a break, instead of supporting research that would help to figure out how to help people in that situation. Yeah. So what we need is intensive caring. Yeah. Intensive caring. And not only is that best for the patient, it's best for the carer. Yeah. It's best if we can. And part of the reason we're so burned out now is that we're not given enough time and resources to do that intensive caring. Yeah. You know, you have to push people through. You have the ambulances are lined up outside the door. Yeah. And
well, this is I feel like a perfect segue into the next point, which is patient-centered care. Mm-hmm. What does patient-centered care mean to you?
Patient-centered care means to me that I do the best I can in presenting options, if they want options. I've had a few patients who say, well, I don't know why I'm even here. Yeah. But if people want options, of presenting the options that I think are reasonable, helping them to figure out, based on who they are, which of those options might work for them. Yeah. And probably from my own standpoint, discouraging things that I think in the long run are not going to help them.
Okay. So that's great, because I feel like you and I have a very similar concept of what patient-centered care. Like, to me, patient-centered care is the embodiment of medical ethics in real day-to-day medicine when we're treating care of a patient in front of us, right? And as you very likely know, in medical ethics, there's like 4 main pillars. There's autonomy, which is essentially informed consent. Patients, just as you said, you present the options and patients can make whichever decision that they want based on their own values and their own goals for the future, right? The second one is beneficence, essentially doing good for the patient.
Beneficence,
doing what is in the patient's best interest. Number 3 is non-malfeasance. Exactly. So do no harm, essentially not doing something that's going to put the patient in a worse situation, whether that's in a physical state or a psychological state or whatever. And the last one is justice. Exactly. So ensuring that we are being fair and equitable in the care that we're providing
Yeah.
to patients, right? And so there are obviously times where some of these pillars are in direct conflict with each other. For example, like, I deal with a lot of people from the downtown east
Yeah.
side who suffer from addiction and mental illness. And, it's quite common for me to have people that are addicted to opiates who come in with really, really bad leg infections.
Yep.
And I want them to stay in hospital so that we can treat them with wound care and
Yeah.
IV antibiotics and get them well nourished and fed and like
Yeah.
get some weight,
Yeah.
And they don't want to stay.
Yeah.
And as long as they are a competent decision maker, meaning that they know, the risks and the benefits of and the possible consequences of whatever decisions
Yeah.
they make, if they don't want to stay in hospital, they can make that decision to leave,
Yeah.
right? And so that's where an example where autonomy and beneficence
Yeah.
are in contrast. And if they're ever in contrast, usually in patient-centered care, we default to autonomy, making sure that patients are allowed to make decisions for themselves, right? Because I think that really historically, medicine used to be quite a paternalistic model of care where, I am doctor knows best, therefore
Yeah.
I make the decisions for you, the patient in front of me. But we've really quickly moved away from that, where it's like, everyone has different values and goals for their own life. We are there to present the different options and, guide them and do this, shared
Yeah.
decision-making model where we can get them the best care possible, right? And I think like,
I guess I have a little bit of pushback on that.
Yeah.
So I refuse to call myself a provider because I'm not a provider. I'm a professional, I'm a physician, I'm a clinician, but I'm not there to be a vending machine. So you don't come to me and ask, and I provide. And I think that we've kind of thrown the baby out with the bathwater in this idea of autonomy and not being paternalistic. So what we've done is we've taken away this paternalistic trained doctor telling the untrained patient what to do, and we've gone to the extreme in some cases of the untrained patient without all the information possible telling the trained physician what to do. And that our culture is saying, well, autonomy trumps everything else, and so if the patient wants it, you should have to do it. But we're kind of schizophrenic about how we do that. So if a patient comes to us and says, a mother, say, brings her child to you with an ear infection and says, I want antibiotics for this. This was on one of the exams that they did for the students to pass,
Yep.
And if the student gave antibiotics to that mom, they failed that station.
Yep.
Okay, we know that that's not good. But, there's all sorts of other things where we have less evidence than we have that, where we've been told that, okay, you need to do this.
Yeah.
You need to step in and do that. And so I think that those pillars are more intertwined.
Yeah.
And I think to be honest, I really think that sometimes autonomy is used as a form of abandonment, as a form of washing our hands. We say, well, that's what the patient really wanted anyway, so, I'm not responsible for that. And it maybe not even consciously, but we excuse ourselves from maybe being more confrontational and saying, look, I think this is a really bad idea.
Yeah.
And we're worried that we're going to incur the wrath of our superiors or our colleagues if we push against some of those things.
Yeah.
They're going to say, hey, that's what the person wants.
Yeah.
What are you doing getting in the way when you know that you can see 3 steps down the line? I mean, we don't let our 6-year-old children be completely autonomous because we care about them, not because we want to be paternalistic, quote unquote. And I think sometimes we aren't paternalistic enough with some of our patients. And, case in point, we decided that it was much better for people who had mental illness to be treated in the community, to be part of a community. Very true. But all they did was open the doors of the mental institutions and turn people loose without support.
Yeah.
Now, a lot of those people ended up on the streets with drug addictions, lighting themselves on fire, having all these horrible wounds and trench foot and everything else, not having their family be able to find them or visit them, when they had it was a more confined existence. It was where they were, but some of them were better off in a residential situation where they could be helped.
Yeah.
Now, I don't have all the answers to that, and I'm not saying that it was right to keep people. I mean, I didn't like One Flew Over the Cuckoo's Nest any more than anybody else did. But somehow, when we just opened the doors and turned them out and said, oh my, look at this, we have drug addiction, we have mental illness on our streets, we could have figured that out ahead of time.
Okay. Well, I would say for the most part, I actually do agree with you on a lot of the points that you made, right? Like, so coming back to the example that I shared where someone needs to be admitted for IV antibiotics and wound care, I'm not going to just be like, okay, like you don't want to stay, goodbye, see you later, here's your sandwich and juice, take off, it's like.
Some people are though.
Yeah, for sure. There are people like that. But no, usually it's like, hey, no, I really think you need to stay. Like this is going to get a lot worse. You might have to have your leg amputated. Please, please, please stay. And I'll like negotiate with them and try to ease the transition into the hospital as much as possible so that there's absolutely no friction for them to stay, you know? But again, if it really does come like push to shove where they are a competent decision maker, I just don't have the legal grounds.
It's the same for me. They're trying to, with the opiate crisis right now, there are so many people that are so afraid to take an opiate medication, even when it would really help them. Or they're so afraid to have their loved one go to a hospice where it would be really helpful. And I do my best at those things. And I understand that. I just think that this focus on autonomy is letting us off the hook in some of these things. So there's the micro level, one-to-one with the patients, but there's the meso level, with our healthcare policies and the macro level of the funding and everything. But we're letting autonomy run the meso level of things so that when you're up against this person in the ER, me when I'm trying to help somebody at home, I don't have the resources that I need. If you had somebody who was assigned to St. Paul's Hospital emergency room, who was an addictions counselor who could come and talk to this person and be safe and do that, you'd have a much higher buy-in from the patients to do that. But we're not at a meso level, we're not supporting that kind of thing.
Yeah, I mean, like, I think you are touching on another really, really, really big contentious issue, that being like involuntary care for addictions. And, I have a lot of thoughts on that. I don't think that I totally agree on.
No, I don't agree with it either. I just, that wasn't what I meant by that. What I meant was, if we are going to put people out into the community, I've seen it happen. When we were in medical school, we were in a small group at our church, and there was a young man who had been hospitalized for a long time with depression. He came to our home group every week, and he was close to being catatonic, And he went out, and during the day he would collect cans and do these sorts of things. It took him about 2 years to come out of his depression. He ended up becoming a teacher, getting married, raising a family, doing all of this. But if he hadn't had that little community for 2 years where he could come every week, there was an older lady who would meet with him during the week and give him meals and do things. But he knew he was loved and cared for, even if he didn't say very much, even if he just came and we all brought our cans and things for him. There's something that's so important about that community, and I definitely think that's the best way to go. But this idea, but you have to fund it. You have to train people to do that. You can't. I think it's just as mean to just turn people loose, which is kind of what we've done. But I agree that it's better to have. I agree that it's better to, when push comes to shove, that you get to make decisions for yourself. Unless you're blatantly suicidal at the moment. There are a few things that are like that, or unless it's a parent that's doing Munchausen's or something like that, and you have to apprehend the child. There's some places where I think we do need to step in.
Okay.
But I understand that, but I think part of the reason we have more people doing that is because we don't have enough supports for them to feel safe to go in the places that are best for them.
Okay. I want to provide you with a hypothetical situation, okay? And hear your thoughts on this. So let's say hypothetically there's an ICU doctor who believes that suffering is from God, and therefore he decides to not provide opioid analgesia to people who have recently come out of surgery or suffer from traumatic injuries.
He's malpractice.
He also believes that believes in divine intervention, and he discourages families from withdrawing care even if the patient is being kept alive on machines, whether that's a ventilator or vasopressors to augment the blood pressure, because he thinks that there could be some kind of intervention where God will intervene and patients should be allowed to pass when it is their time. What are your thoughts on that?
Well, the first part is just malpractice.
Okay.
I mean, if somebody's suffering and that's not a controversial thing.
Okay.
I mean, there are very few doctors in the world who would say, "Oh, don't give opiate medication to patients who are suffering legitimately." We're not talking about addictions and all of that, but post-op, palliative care, any of those things. That's beyond mainstream. That's just like 99.9%. And I would say that somebody that goes against that that's just malpractice.
Okay.
Christian physicians have been at the forefront of providing palliative care and dealing with suffering. That conference that I went to when I first found out about palliative care, Dr. Mount is a Christian. John Scott is Catholic now, but he was a Presbyterian minister at the time. David Skelton, who started St. Boniface in Winnipeg, he is an Anglican minister as well as a geriatrician. And Sister Noella Kenny is the head of pediatrics. Dr. Sister Noella Kenny is the head of pediatrics at Dalhousie at the time. So it's not antithetical to the Christian faith. In fact, you look at all the people down through the ages. Dame Cicely Saunders felt like she had a word from God to help her found St. Christopher's Hospice and do all these things. So that's just dumb.
Okay.
I mean, really.
Okay.
But the other part of it, I think there we have to take a much broader view of things. And I think that I do think that sometimes we in medicine give up too soon, not because the person's going to recover, but because the family isn't quite ready yet. So one of the things, this is another thing I taught my comm skills students was, we say in the ER, in the intensive care unit, and we watch the numbers. We see the kidney function is going down. We see all these other things. We know that the canoe is headed for the falls.
Yeah.
Okay?
Yeah.
But all the family sees is treat.
Yeah.
Work really hard, put in the lines, get the blood work, do all of this. They have no idea that the falls are coming.
Yeah.
So it's our responsibility to be saying, hey, we're watching this. It's not looking good. We're thinking that we're not going to be able to do much more from a medical basis within a few days, within a week. One of the things that I talk to patients and families about, I say, it's like your loved one is on a tightrope, a high wire with no net. And, the thing that's odd is sometimes they can stay up there for quite a long time, but when they fall, that's it.
Yeah.
Or another example I give is it's like your loved one is in an elevator that's not working, and you get this drop, and then it kind of bounces for a little while, and you're never quite sure what's going to happen, and then boom, but it never goes back up to where it was before, or very seldom. No, I never say never, but it's very rare that it goes back up to where it was before. So that it's our job to help the patients and their families get to that place where there's a consensus about what needs to be done. And the team is with it so that there's not this lingering nastiness, this taste in their mouth of the doctors killed my dad.
Absolutely. Yeah.
And, you know, I think an extra day or two in the ICU and the money that you spend on that compared to what we call morbidity, that down the line where all these other family members are going to say, I want everything, everything, everything because of what happened to their mother.
Yeah.
I think some of it is that we need to be better and have the resources and the time to be better at helping families understand this and figure out, like that doctor just is, he's not a good doctor if he's doing that.
Yeah.
You know, that I don't want to give up on people too early either. You know, I heard a story the other night where somebody came into the emergency room with a broken hip and was offered MAID, you know, because of...
I think I saw that segment on like CTV or something like that. I have some thoughts on that. Like, I don't totally buy the story. Just like, I've never heard of any emergency physician offering someone MAID for a hip fracture. If they did, they are a terrible doctor.
Yes, okay.
Like, straight up, they are a terrible doctor. Like, but like, even in other circumstances, even if someone is suffering from terminal cancer as an emergency physician, that's not something that I would ever do. You know, it's just not within my wheelhouse. And
well, there are some who do believe it. You know, a friend of mine was approached by a fellow emergency room physician who said to him, you know, all of us in the ER should get trained to be MAID assessors, so we could do the first assessment, and then if the person wanted to go, all we'd have to do would be to call the MAID team. So I think there's some of that out there. I don't think it's the norm. I'm not trying to say that.
Yeah, I think in regards to many different issues, the pendulum swings so far back and forth, and if people are trying to convince emergency providers or acute care providers to, you know, one, be trained in offering MAID, and to be offering that as a major contender for medical care when something is that truly reversible, like a hip fracture that can easily be fixed with surgery, I do not agree with that. No, I wholeheartedly disagree with that.
There are some places, like Nova Scotia right now, is requiring physicians to offer it as, you can lose your license in Nova Scotia for not offering MAID in a situation where it might
even ER doctors.
Well, I don't know about the ER doctors, but family doctors and others are, and surgeons and other people are being told that, you know, if you have a person who would qualify and you don't offer it as quote unquote a treatment option, you can lose your license. They're very, Nova Scotia, the college there has been very militant about this.
Yeah, I would need to look at that and actually like verify the facts. It's like part of me just doesn't want to believe it.
Oh, you can. It's out there. You can verify it. There was a group of more than 40 Nova Scotia doctors who hired a lawyer, put their names, the names were kept at the lawyer's office, but put forward to the registrar and to the Minister of Health, and the registrar just basically told the Minister of Health, oh, these people are just whining. But there have been several people who have been, one of my friends in Nova Scotia has been pulled before she's had a complaint because when the person had cancer or something and said, well, I just want to have MAID, she said, well, let's try some other things. Let's look at some other things. And made a complaint, and she's got it on her record now.
Wow. Okay.
So there are other places. So Nova Scotia is the worst right now. Yeah. But there are other places across Canada where it's kind of variable. And BC has not been that way. Yeah. So I agree with that. But, you know, there's just some stuff that's there.
Out of curiosity, I did look at the statistics of MAID in Canada compared to other countries. And I was really surprised and shocked to see that Canada does have the highest rate of MAID. Something like 5.1% of deaths in hospital or under medical care are from MAID, and that's like I think compared to like something like less than 1% in the USA.
When it's assisted suicide, that's the difference. If the places where it's been by lethal injection, the growth has been exponential. the places where the patient has to have some kind of agency in it by taking the pills or do whatever, the growth has been steady, but it's been slow. So, for example, Oregon, where they've had assisted suicide for since the late 1990s, it was kind of a soft entry into things. For years they were 0.2 to 0.3% of all deaths, and now they're up to about 1%, 1 to 2% of all deaths after almost 30 years.
Yeah.
Whereas us in the first 10 years, we're nationwide, we're up to more than 5%. And there was one quarter in Victoria that one of my palliative care colleagues who works in that area said that 12.3% of all the deaths in Victoria in that health region for that quarter were lethal injection deaths.
Wow.
And people were complaining. I think the other thing about it is that, I've had numerous people who have come to me with complex issues.
Yeah.
Okay.
As a palliative care doctor, I'm not the slightest bit surprised. Yeah.
Or even people who just have complex pain issues and reflex sympathetic dystrophy or whatever we're supposed to call it now. All of these things. And for them to get in to see the complex pain folks at St. Paul's Hospital, it can take 12 to 18 months for them to be seen.
That's
crazy. You can be dead very quickly.
Yeah.
And I had one woman who I got called about, and she came to see me and she said, I don't want to die. I don't want to do this. But the only thing I've really been offered in a timely manner is MAID. And I've got a husband who has disabilities, and I don't want to leave him behind, And I was able to, working through her family doctor, fortunately, in the past, she had seen the people at the complex pain clinic. And I was able to call them and say, look, this is what's happening with this woman.
Yeah.
She really needs to be seen on an urgent basis. And they said, well, we'll put her down for cancellation, and one came up, and so she got to be seen within a month.
Okay, but that's clearly the exception, not the rule, right?
Yeah.
Yeah, that's unfortunate.
It's just, gosh, what is it? And I think here's the deal. We're talking about all these things as being autonomous, but what does it say about us as a family, as a community, if people are able to get a lethal injection so much faster than they're able to get care for what they really need, when they don't really want to be dead? They just don't want to have this awful pain. What is it? We've had this thing in Canada, this really important part of who we are, that we are altruistic. Yeah. Okay, we're willing to stand in line. We're willing to welcome refugees. We're willing to have, not have all the bells and whistles on our healthcare so that everybody can participate. We're welcoming. We want to be inclusive. We want to do all these things. What does this say about? What is this doing to our national identity, to our national psyche, if we get to the place where we start to realize that that's what we're doing? We're saying, okay, that's what you want, we'll do that. But the person who's in terrible pain, or the person who has no supports, or the person, it's not really a choice they're making.
Okay.
So that bothers me, because I think that, I had some long discussions with Margaret Somerville about this. And I met a man in Winnipeg years ago, he's passed away now, who was he had post-polio syndrome, and he was in a wheelchair, and he was one of the leaders in, well, maybe not just post-polio syndrome, I think he had polio when he was younger.
Yeah.
And so he was one of the leaders of the disability community there.
Okay.
And we were talking about things at the end of life, and this was before any of the laws came in. And he said, for years, for millennia around the world, people have had a wisdom about what it means to die and how we do that well and everything. And we're just throwing that out the window. And that got me thinking, and I thought, our Hippocratic tradition of saying every life matters, and I'm not going to help you even if you ask me to die. that's kind of like an old growth forest for us in our in our in our philosophy, in our morality, all these things that we say, we're going to protect this. We're not going to kill each other. That's
Yeah.
what's going to happen.
Yeah.
And so what we understand that when we cut down our old growth forests, that we're responsible to the generations that come after us for the physical environment that we have.
Yeah.
And I would say that we're just as responsible to those who come after us, to my grandchildren and your grandchildren when they come, for the metaphysical environment that we're leaving. And if the metaphysical environment says that there are some lives that aren't worth living, and that sometimes taking a person's life is better than caring for them,
Yeah.
then I'm concerned.
I don't disagree with any of the points that you said. But the one thing that I will say is that, just like you, I've seen so many patients that come in suffering. I recently saw a younger patient with terminal cancer with mets to their spine, recurrent small bowel obstructions, who came in, and first thing the patient said to me was, "I want MAID.
Yeah.
I want it to be over. I want my suffering to be over."
Yeah.
And so, this is someone that's already had, radiation and chemo and all the different things. And the patient has already come to the decision that is the way that they could best be treated, to protect their own dignity and to die in a way that, I guess, gives them power and autonomy in their last final moments, right? And so, I said, I'm absolutely happy to refer you to a palliative care doctor. That's not something that I can offer you, but certainly that's something that I can offer you. And, this isn't someone that death is something that's abstract. It's something that's very, very real and foreseeable. So this is if we're talking about MAID, oftentimes it's separated into track 1 and track 2, right?
This is track 1.
This is track 1, where someone has terminal illness, terminal cancer, ALS, severe Huntington's disease, where death will happen in the foreseeable future. It's just really a matter of time, and it gives people that autonomy to die in the way that they see fit, compared to track 2, which I am probably a bit more hesitant. I'm not totally rah track 2 MAID kind of thing, that's where death is not really imminent, but people are suffering and they are opting for medical assistance in death because that's the way that
just what we were talking about before.
Yeah, exactly. So, on that point, I am hesitant. I'm not totally on board with track 2, especially when it comes to discussions about implementing MAID for mental illness and depression, where it's there's so many different therapies that are coming out where we could potentially treat these people and give them a happy, meaningful, high quality of life moving forward. Whether it's electroconvulsive therapy or psychedelics or whatever it is, So that's something that I'm much more hesitant about. But for the track 1 people, I'm kind of the opinion that, man, if they've explored all their options and this is really what they want, why wouldn't you do that? That seems compassionate to me.
Well, there's a couple reasons. First of all, I totally understand how that woman would want that. Okay. My colleague, Dr. Romaine Gallagher, who's been a big St. Paul's person, she's retired now from that, but she and her colleagues wrote an article that physical suffering that leads to MAID is actually a form of malpractice. That we need to have, there's enough out there that we could control this woman's physical pain. We can do that. Whether or not we have the will as a medical community, we have the will as Canadian people to implement those things is another issue. So I know what you're going to say.
Well,
just
okay,
let me say this. Let me say this. Okay. So if I want to take the physical suffering part of it off the table.
Yeah.
Okay. Because she should not be, well, if she has a total pain crisis, she should be in the ER. People do have these things that happen, like she ruptures her bowel or she bleeds or something like that. She could come to the emergency room for something like that. But basically, for just basic pain control, we do that pretty well at home. We've had people on lidocaine drips at home. We've had people on spinal things at home and everything else, so that have, been able to do Lego with their 5-year-old daughter and things like that.
Yeah.
Okay, so, but the other piece of that is, okay, what about the people who just say, I've had enough. I've had enough. I don't want any more treatment. I just have had enough. I've suffered enough with this. I'm ready to go. I want to go at a time when I can call my family. We can just do this and everything. Well, it's not that simple, is all I can say. That I have had a number of people who have come to me and who have said, that was the worst experience of my life. Everybody else said that we should just let him go. It should be fantastic. But I was not able to be present for those last moments because all I kept doing in my mind was counting down the hours. And I was such a mess by the time I knew the doctor was going to come and he was going to be dead that I couldn't even be present for him for that last bit of time. And that's not an unusual thing. So,
but I guess my pushback against that is that it's not entirely about the family members. It's really about like the patient
that's not true. That's not true. Because in palliative care, we talk about the unit of care being what I love the French version of it, les prochains, the people who are close. Mm-hmm. Okay, it might be family, it might be friends, it's whatever the Hawaiians call it, your ohana, right? Mm-hmm. And one of the things that I ask people to think about is how autonomous is this really? Okay, if you are going to commit suicide, mm-hmm. okay, kill yourself. It's not something we encourage. We don't love it. If you take too many pills, you go out behind the barn and shoot yourself. We grieve that. We second guess ourselves. How could we have stepped in? How could we have known? But when you decide to have a MAID death, it is not completely autonomous. It's not. You have doctors, nurses, pharmacists, healthcare workers, the people at the funeral home, the people who make the laws, first responders, family, friends. There's social workers. All these people.
Wouldn't you call those safeguards, though, to make sure that it's actually done in a reasonable manner and not just willy-nilly, oh, you get MAID, you get MAID, you get MAID?
I'm just saying that all those people are complicit in the death, okay? They participate in it. The nurse who starts the IV, the doctor who pushes the medicine, the pharmacist who prepares the prescription. All of those people are involved in it. Okay, complicit is kind of a bad word, but they all have a part to play in that death. And we understand in our culture that autonomy is not absolute. I don't care how good a driver you are, you're not allowed to drive 120 kilometers an hour down Fraser Street. In Vancouver, you're not allowed to smoke a cigarette outdoors on a public beach because of how it might affect other people. I can't have a little nuclear reactor in my backyard because I want to live off grid. Heck, I can't even keep a donkey or something that I might like to have. The number of dogs I'm allowed to have is monitored. All of those things. And we understand that we accept limits to our autonomy because of how it affects people around us. And to think that how I die has no effect on my world and the people around me, and it's all up to me, it's all about me, is just a fallacy. How each one of us dies makes a difference to how all of us are going to die and how all of us see ourselves and what kind of a culture we're building.
Yeah. So, I mean, I do hear your point that some family members might have had a really bad experience because of like the anxiety leading up to it. But I feel like for the most part, most of the people that I've heard that have had family members, even people that have commented on some of my posts talking about their experiences with MAID, it was overall a very positive thing because people were able to leave this world in a very peaceful way without suffering, right?
We provided a way for the sufferer to go, so we didn't have to watch it anymore.
Well,
it's part of it, Jeff.
Well, okay, like I think it's. Do you believe in comfort care? If someone
Oh,
is,
yeah.
yeah.
Oh,
So
yeah.
then, so how do you draw a clear line between comfort care and MAID? Because I feel like the lines can kind of get
It's
blurred between
okay.
those two,
Here's the
right?
deal. It's all about intent. Okay? It's intent. Now, people say, oh, well, you're just as dead. Doesn't matter what your intent is. Let me give you an example. Our entire legal system is based on intent. If I tell you I was driving my car this morning and I hit a little boy on the street in front of my house and I killed him with my car, what's my punishment?
Yeah. I mean, if you were intentionally doing that, intentionally trying to
So
hit,
you can't tell. You don't know.
Yeah.
Because what if he was chasing a ball, he ran out in front of me, I slammed on the brakes, I wasn't texting somebody on my phone, I wasn't drunk, it would be sad, he would be just as dead, but I had witnesses that showed that I wouldn't even be charged. Okay. But if any one of those things was involved, then I would be charged.
yeah,
And if I hated the little guy and I was waiting around the corner until he crossed the street on his way to school and I ran him down,
Yeah.
That's murder. And so the intent really matters. And I think that's the bright line that I want to draw. I have no problem with withdrawal of care when it's no longer serving the person. I don't like the word futility because I think it's been used against patients and families. Oh, it's just futile. Nobody's futile to me. It doesn't mean that the care has to continue, but when the burden of the care becomes too much and it's not doing any good any further, it's gone to make it even worse for the person. Then I have no problem in withdrawing care. I have no problem with providing comfort care. I've been doing it for over 30 years.
Yeah.
And I have no problem in saying, okay, if you don't want to have these other things that may prolong your life, you don't have to have those. That's fine with me.
Yeah.
But when we make a conscious decision, we come into a room, we bring medications that are going to end this person's life with the intent to do that.
Yeah.
Because, when we withdraw care, we don't say, okay, well, up until recently anyway, we didn't say we take somebody off a ventilator. We keep them comfortable. But if the person doesn't pass away right away, we don't say, oh, well, we need to inject them with something so they're dead. Our intent was to remove a treatment that was no longer helpful.
Okay.
So I think that there is something really important as members of the human family that we don't cross that bright line that says we don't kill each other.
So, okay, let me present a hypothetical
Okay.
case to you, okay? So I have a patient in the ER who
Yep.
has terminal cancer, has recurrent small bowel obstructions. The patient has to drink out of a straw because if the person is eating any solid foods, it causes severe abdominal pain, bloating, nausea, vomiting. They're wasting away. They have literally no muscle or fat. They're just skin and bones. They're so weak that they can't even get out of bed.
Yep.
And they say that, tell me that they want to get MAID. And I refer to you as a palliative care doctor, saying that they want to get MAID. And that they've already explored all the different pain modalities, all the different supports that they can have in the community. And really, the only thing that they want to do is to end their suffering, and they want to go.
Well, you don't send them to me then. You call the MAID team. If I were called to see somebody, I mean, I've gone in to households before where the person has MAID scheduled for the next day, because the nurses are saying, I just want to be sure that everything's been done. And I am respectful of the person, and I say, look, one home that I went into was a very successful businessman who had his MAID scheduled for the next day. His wife of many, many years was distraught about this because she was saying, I was hoping he would just go to sleep, and die and do that. I didn't want it to be so formal like this. One of his children is there saying, Mom, you need to get over yourself. This is what Dad wants. We're going to have it. I go to see this gentleman, and he actually had none of those things you're talking about. He was actually in pretty decent shape.
Yeah.
He hadn't even gotten a commode in his room yet. And I said to him, you know, I'm not afraid to say, why are you wanting this?
Yeah.
You know, because I think that that's a really good question. You know, why are you feeling like you'd like to have this? You know, now some of our nurses who ask that in the home have been reprimanded by their superiors to say, well, you're just getting in the way of the MAID team. You need to just call the MAID team. If somebody says they want MAID, don't be asking them questions. So to me, that's a failure of our medical system. If somebody is really wanting MAID because they're worried that they're not valuable to the people around them anymore, or they're not loved, or they're not cared for, or they're too big a burden, all of those things. Anyway, so I said to this person, I said, why are you wanting this? What's behind this? And he says, well, there's just no joy anymore. There's just no joy anymore. And, you know, I thought to myself afterward, I talked to him about all the things that were available and everything, and he just said, no, that's it. So, you know, I didn't stand up and yell at him or do anything like that, but I felt afterward, you know, before this was legal, 15 years before or 10 years before, we would have worked really hard to reframe hope for this man, to help him figure out how there could still be joy in his life. And it doesn't just have benefits for him. What he would end up having at the end of his life is an understanding that the people around him loved him, not just for the money he was bringing in and the things that he could give them, but just for who he was.
Yep.
And the children and his wife, who maybe hadn't been able to give much to a guy like that, could have the sense that they were able to help him eat, or they were able to stay up with him at night and read to him, or they were able to, you know, even clean his body or do those other things. And there's something that's like gold refined by fire that you get when you are in a tough place, when you're in a place that's challenging and you come through and you care for people you care about, that you can't get any other way. And I think that when I see people, I mean, I've seen some heartbreaking people in my life. You know, that patient that you're talking about would be one of them. I did a home visit on a young mother who had 4 children under 10. She was in her 40s. She's in a neck brace because of all the metastases she has in her neck and her spine. And she says, am I just going to crumble? Am I just going to crumble? And this was before MAID, and I said, no, we're going to come alongside you and we're going to help you and we're not going to leave you alone. And what we did by doing that is we showed her children that it's important to care for one another, and that you can't, you know, if one of those kids ever got a spinal cord injury, they know that people cared for my mom, even when she wasn't physically pretty. Okay, this person has to drink from a straw. What about all those folks that we see in their little scooters and everything, who every day have to drink for a straw and say, oh, well, I don't want to have anybody helping me with my toileting. So Marilyn Golden is a woman in the United States who's pretty feisty, but she's a disability rights activist, and she says, have we gotten to the place where we're willing to have people die simply because they don't want somebody to wipe their butt? You know, so there's parts of
it's a little bit more complicated.
Well,
though.
it is, but she's part of the disability community. She's in a wheelchair. She needs help with that. All of those things. And what people from the disability community are saying is that most of the time, the reasons that people give, and you look at the stats from the reasons that are given, are things like not being able to do the things that bring them pleasure that they've been able to do before, not being able to care for themselves, being worried that they're going to be a burden on their family, all of those kinds of things.
But those are kind of valid reasons too, right? Like it depends on the individual and what they value, and
yeah.
You know?
But is it a valid reason for us as a society to say, okay, we agree with you, your life is not worth living? That's what I'm saying.
But that's not for us to decide. That's the whole point.
Well,
that
it
I'm
is
making.
though. It is. We as a culture get to decide who we protect. Do we protect everybody, or do we only protect those people who don't have disabilities? Whether the disability is you're born with it, or whether the disability comes because of as a result of an illness.
But that's what I'm coming back to, is autonomy means that they have made that informed decision, right? They have looked at all the various issues and they've decided for themselves, this aligns with my values and this aligns with how I want to go. And so who are we to argue?
They aren't just doing it. It's not autonomous. They're asking us to say, yes, this is good. That's what this is in our society. We've decided that there are some lives that are not worth living.
Well, I would frame it as like, as a physician who's treating patients who come in with many different life circumstances, whether they are drug addicted, whether they have a different outlook on life. My moral compass that I've come to is that I'm going to leave my own personal beliefs at the door and treat the patient that's in front of me based on what they value. It's not based on what I personally value, you know?
But you don't do that. You don't do that at all. If somebody came to you, all right.
Well, I wouldn't personally be administering MAID. That's not something that I do.
But you don't even do that with leaving your personal values at the door. If somebody came into you and said, you know, the thing that I really like doing is going over to the local school and picking up 3 little girls and taking them home and having sex with them, you would not be saying, oh, that's your personal value.
No, but I feel like that's a false equivalent, and it's quite extreme, right? Obviously, in that situation, I'd have to, there's someone else's harm.
It's pretty extreme to say it's okay to kill somebody. Now, come on.
I think these are two completely separate things. Like, the example that you're saying is like someone that's taking young, innocent children that have many, many potential years of quality of life ahead of them and taking them and, like, I don't know, torturing them or doing whatever to them, right? That's not at all the same as the hypothetical patient that I've presented you with, who is actively dying of a malignancy, who essentially, by easing their suffering, you get that double effect of actually allowing them to pass in peace.
That's different. Double effect is different. I am all for giving the person, even if we have to do sedation, giving the person everything they need to have to be comfortable at the level that they want to be comfortable at. Not everybody wants to be completely out of it, but I'm okay with
so
that.
Then you would administer MAID? Is
that,
no.
Not,
so how would that look? So you would administer, say, big doses of midazolam and...
no, I would give what I call... I'm losing the word here. What I call the proper sedation, so that you would give appropriate sedation to get the person to the level of comfort that they're looking for.
Okay, so you would give them very large doses of, say, hydromorphone.
Depending on what they needed.
Okay, to alleviate the suffering, and by doing that, they would stop breathing and pass away?
No, not necessarily. In fact, the palliative sedation at the end of life, the studies show, if you're going to evidence-based medicine, that it doesn't actually shorten the life. And part of the reason that we think that is the case is this part is speculation, is that the person is able to rest. And so they're not fighting against all of those things and having all of that happening. But the proper, proportional, that was the word I was looking at, proportional sedation. So that, and sometimes, you know, all the person needs is actually some time to have a good rest. So, for example, I don't know about your family, but when I was in the middle of labor, I had a completely natural...
Before you tell the story, I just want to come back to like the practical application that you were talking about. So you were saying you believe in double effect.
That's what I'm going to talk about. Okay. Yeah. When I was in labor, I would have paid a lot of money for a 5-minute nap, but I didn't have that opportunity. You know, I didn't have an epidural or anything, but you know, it would have meant a lot to me. So sometimes with the sedation, we have found that all the people need is to say, okay, I need to be out for a while, just so I've got a rest, and then I want to come back and talk to my family or do whatever.
Yeah.
So the person that you presented to me was not somebody who had what I sometimes call the dwindles, where they were just kind of, this person was on an active trajectory of dying. And throughout my entire career, I have gone above and beyond, done whatever I could to keep that person comfortable without stepping across the line of actually intending to kill that person. Okay? And there's a beauty, and I don't expect everybody to see this, and I don't expect everybody to agree with me. All I can say is, over my 50 years in medicine, even before palliative care, I was always drawn to those kind of people. But and the 35 plus years that I've been doing palliative care, I have seen it over and over again that there's healing that comes. When you provide that space, that sort of liminal space for people to have that opportunity to say, I love you, and it doesn't matter to me what you look like. It doesn't matter to me what abilities you have. It doesn't matter what you can do for me. That there is so much healing that happens on both sides of that equation. And you've seen it too, I'm sure, when you've got somebody who's, I'm sure there have been people in the ER where you've been able to get a hold of a daughter or a son of somebody who's an addict who's probably in his last days, and they come down and they say, oh, Dad, I've always loved you. And the healing that takes place there, and the dad that's able to say, I'm sorry I wasn't as good a dad as I really wanted to be for you, and how that carries on as a legacy for that daughter or son going forward, that he really did love me, but he just had this disease or addiction problem that he couldn't love me the way he could. And I was able to tell him at the end how much I loved him. And there's something that's so deeply human about coming along somebody in the darkest hours of their life that builds something into us, builds something into our culture that is what I call it, gold refined by fire. It's things we can't get in other ways, because it shows that it doesn't matter. I'm going to fight for you.
Yeah.
It doesn't matter what you look like. I'm going to fight for you. And if fighting for you means I get you the pain relief, if fighting for you means that I need to keep other people away who are trying to bring you down, I will do that. If fighting for you means that I need to work on the rest of the family so that they'll be able to let you go because you're ready now to do that, I'm going to do that. But I'm not going to participate in causing your death.
Okay. Yeah, those are really interesting insights. Thank you for sharing that. I guess, for me, it's a lot more hypothetical than it is for you as a palliative care doctor, right? Like, the closest thing that I've dealt with in that realm is providing comfort care to people that are actively dying. Like, they can't breathe, their oxygen saturation is low, their blood pressure is tanking. And I provide morphine or hydromorphone, anti-nausea medication to ease their suffering as they are passing by natural means, right? So obviously that is quite different from me being they're kind of dwindled, they've got the dwindles, as you say, and then boom, you're gone, So maybe my opinion would change, if I was kind of thinking it on a very different metacognitive level, so to say, if I'm actually the one pushing the drugs and being the so-called dealer of death. But I kind of have always just thought of it as compassionate care and easing suffering and really honoring patients' wishes and quality of the time that they have, or the quality of their autonomy over the quantity of the time that they have left on earth. But so the next thing I want to talk about is contraception. And I know in the quick rapid fire things you said, maybe, I think on some topics. So maybe you can just elaborate, condoms and oral contraceptive pills or birth control. What are your thoughts on that?
Well, there's not very many of my patients that are too concerned about contraception at this point. And I think that I think it's something that's kind of personal for each physician as well. I don't have any problem with barrier methods, or with most of the time with the birth control pill. I prefer to have ones where it's very unlikely to have a post-conceptive effect.
Like Plan B kind of thing?
Yeah, I'm opposed to that.
Yeah, okay.
I just think if we're talking about science, that you start as a fertilized egg.
Yeah.
It makes no sense to me on anybody's timeline that somehow you become a person some other place. That's just kind of where I go with the science. And, I don't like anything that would interfere with implantation, or would happen sort of with the morning after pill and other things like that. And I don't even really think, here we are worried about all these hormone levels, and then we're willing to give these huge doses of hormones on Plan B that feels kind of schizophrenic, that we have our teenagers taking those things and we're worried about their plastic water bottles.
Yeah. Maybe I will tell you a real story. So when I was in medical school, I had a classmate of mine who was a devout Catholic, and he had what I would consider quite extreme views.
Yeah.
He was anti-contraception, anti-condoms, anti-birth control pills, so far to the point where he said that if a young woman had come to him asking for oral contraceptive pill or the IUD, he would refuse care, and he would also refuse to refer the young woman to another provider who would be willing to offer that to him. This raised a lot of alarm bells in my classmates, and he was actually reported to the dean, and he had to sit down with the dean to actually talk about patient-centered care, because it really felt like he was imposing his own religious views and ideology on the patients that he would be ultimately caring for, right? So what are your thoughts on that?
I think that there are probably enough Catholic patients out there. If you're just looking at it from a democratic standpoint, there's probably enough Catholic patients out in the world who would be really grateful to have a doctor that shared their views. Okay, we understand this about people from First Nations. We understand this about other minorities.
I think that's besides the point, though.
Not really.
Well, because the point that I'm trying to touch on is like the doctor has a specific personal set of views and a religious standpoint, and they use that.
Yeah, there's people that are going to want. I know that there are people who want to come to my colleagues who are family doctors who refuse to participate in MAID because they know that on their worst day they're not going to be offered something that is going to do that. Now, I think that there are folks who either because they're Catholic or because there's a big group of women now who don't want anything to do with anything hormonal, because of stroke risk and some other things like that. There's a big group of folks that are out there that are kind of, there's a funny little strange bedfellows of people doing natural family planning who are, from the Catholic standpoint and then from the feminist standpoint too, who are doing that. But, I think that I think that one should be willing to provide information as to where a person can get help with this. Now, somebody who is it's really not that hard to find contraceptives. It's not like he's the only person in the entire world that can provide it.
Yes, but in order to get oral contraceptives or an IUD, you need to get that from a physician.
Yeah,
right? Yeah.
But there's every walk-in clinic is going to do that for you.
Walk-in clinic?
Oh yeah, you can get oral contraceptives at a walk-in clinic. In fact, there was a court case in Ontario that had some of these similar issues in it, and the before it went to court, it was before the Ontario board, like our BC college, right? It went before the board, and the one member on that board who was an abortion provider even just said, look, there's not a 16-year-old girl in the city of Toronto who doesn't know how to find somebody who's going to help her get an abortion or get pills or an IUD or whatever. There's lots of clinics. There's Planned Parenthood type clinics. There's all kinds of places that you can go to do that. It would be different if this were something like, let's say, I would agree with you in terms of something. Let's say you were doing, you're a neurosurgeon and you do that fancy threading the thing to get the clot out, with the little cage, and you say, okay, I'm not ever going to do that for anybody of a certain race. That's, I wouldn't put up with that. Yeah. But that's something that's super specific and really hard to get, and special trained. This is, to me, it's not as big a deal. And to be honest, the other people who are willing to provide that whole range of services, okay, if I have a 13-year-old daughter who I'm not so sure that that's going to be the best thing for her, I would like to know that she's going to go to see my Catholic physician friend who's not going to be offering her that as a way out, but it's going to sit and talk with her about who is pressuring you at 13 years old to try to get contraception.
Well, I think pressure, that's a lot of assumptions. I think the reality is that most kids in their teenage years these days especially are having sexual intercourse, and being able to provide contraception, whether it's a barrier method through condoms or contraceptive, is something that I think the individual should be able to make for themselves. It shouldn't be my whole point is that the physician should not use their own religious moral compass to put up these barriers to care for patients.
Yeah, it just depends on, part of it depends on whether you have come to the conclusion that this is, it's another part of that beneficence thing. Is this really in the patient's best interest? Does the literature show that it's in a 13-year-old girl's best interest to have sexual intercourse?
Well, I think it's fair to preach abstinence to 13-year-olds, but whether a 13-year-old girl or boy is going to listen to that and actually abstain from having sexual intercourse is the research shows that most of them are going to be sexually active, and therefore...
Well, it's about half.
Half is a lot.
50%
is a lot.
But it's not everybody. Okay.
But so for the 50% of people that are going to be sexually active, you're saying that they shouldn't be offered any form of contraception?
I'm not saying that. I'm saying that if you have a physician who feels that this is not part of his or her practice, that they should be able to have that. Now, this is not my area of expertise, but I do know some of the folks who have had that stand, that they taken that stand, and they try very hard to have really good discussions with the young people in their practice to help them understand, what are the risks and the benefits that are going on. It's not hard to find a condom. That's not hard to find. And there are other barrier methods that are not that hard to find. There's clinics everywhere that can do that. And just to say that, well, we're not going to, you're a bad doctor because this part of your belief for which you feel that you have really good evidence on your own, that it's not, maybe it's participating in something that you don't feel is right for this patient. Okay, at a certain level, that's the way they see this.
Yeah.
I'm not saying that that's the way I see it. Okay. I'm just saying that I think that there's enough of us around as physicians that we shouldn't be focusing in on these little flashpoints and causing more rifts within the medical community over something where somebody else can easily pick up the slack on that. That's the same thing with MAID. If there are those of us who do not want to refer, who do not want to do any assessments, who don't want to be involved at all, if we're up to 5 or 10%, that means 90% of the patients don't want anything to do with it. So why do we need to have everybody on board who's willing to do this?
Yeah, okay. I hear that perspective that there's enough other doctors to pick up the slack, but I think it really comes down to, like, just as we were talking about before, the relationship between a patient and a physician is special, right? Like you're given a special amount of trust.
I understand what you're saying.
And
you're
so,
saying that I should, but see, here's what we were talking about before too, that who I am as a person is part of what goes into that therapeutic relationship. And if I really believe that something is wrong, I personally don't believe that contraception is wrong, okay? But the people who are not providing it, they're not declining to provide it because they think it's a good that they're withholding. They're declining to provide it because they think it's a moral evil.
I think like an analogous situation is like, well, this is truly a form of harm reduction, right? Like preventing unplanned pregnancies in young teenagers.
That would be the way I would see it.
It's the same kind of approach for people with addictions using opioid agonist therapy to get them out of that vicious cycle of intoxication, withdrawal, craving, so on and so forth, right?
I agree with those things too, but I think there are people who say that and I think some of the contraceptive people would say the same kind of thing, that we're putting a Band-Aid on a big wound, and that what we need to be doing, and they feel like they're participating in the harmful part of the culture that is signaling to young people that it's okay to go ahead. So, I'm probably not the best person to do this because I'm not in their shoes completely, but I know enough folks who feel that way that I can say that it's not something that is done without thinking about it. It's not something that's done in a punitive way, and it's not something that's done without really due consideration and real strong convictions about things. And I think there may be people from other cultures who come to our country and who are part of our medical system who have similar things from their own cultures that, and we understand that we need to kind of accommodate to a certain extent those things, not to the point of genital mutilation or anything like that, but we do understand about some of these things, and I think that that's something that just because our Catholic colleagues are people who have been here for a long time doesn't mean that we can't offer one another some understanding and understand why they feel that way and help each other out. You may actually have patients who don't understand why you believe that a certain way, and you say, well, I've got this other colleague, and I can send you to that person, and we can help out.
Okay. So maybe we'll just talk, we were just talking about contraception, which obviously segues into abortion. So obviously you are anti-abortion. Do you agree that a therapeutic abortion would be necessary and ethical for any conditions where a mother's life is at stake? Ectopic or tubal pregnancies, septic pregnancies, molar pregnancies.
Oh, yeah. Well, that's not even.
Preeclampsia.
Well, it would depend on, I suppose it depends on what the definition is. I think that there, certainly for the molar pregnancy and for the ectopic, where they're not going to live, anyway. But some of the other ones, like the preeclampsia or other things like that, I think there's a difference between saying, okay, say for preeclampsia, we're going to have to deliver this baby early, and the baby's going to have to take its chances, versus we want a dead baby. Okay, so I would draw a line there and say, yes, if the mother's life is on the line, we go ahead, we deliver the baby, and we do whatever we can to resuscitate the baby. In terms of other things, like for example, with a fetal anomaly.
Yeah, like anencephaly, for
Yeah,
example.
okay.
Yeah.
So this is kind of an interesting thing. One of my colleagues was Byron Calhoun, OBGYN in the US, and he developed the concept of neonatal hospice. Okay, where when there was a diagnosis like that, where the baby seemed to be incompatible with life, that they would support the family. And he actually worked in the U.S. Army at the time, and he even got permission that if, as the baby got to term, it looked like the child was going to die, that he could do a cesarean section so the mother could hold a child, living child, well, before the child died. And so they put together a whole bunch of things like the photographers, the Now I Lay Me Down to Sleep folks, and helping them with little kits that they would have to take footprints and handprints and helping them to figure out what kind of subscriptions that they needed to cancel, like the new baby things that welcome wagon stuff,
Yeah.
things like that would come, and get counseling and all of that sort of thing after. And they did studies on this, and they found out that the families that had that kind of support and were able to carry the baby as far as they could and then grieve it
Yeah.
did better than the ones who went for an early termination.
Yeah.
And it was so compelling that insurance companies in the United States, who are all in it for the money, actually started funding the neonatal hospice because they realized that if they funded that, they had less to fund in the mental health stuff for the family afterward. So it's another way of just saying that we're all members of the human family, and we honor and support you. It doesn't mean that I am nasty to women who have made a different choice. I do think it's sad when you look at the number of Down syndrome children that are aborted. Many people living with Down syndrome live great lives and have good things. And what kind of are the standards that we're measuring? It's a little bit, again, like the end of life. Like, what are our standards that we're measuring where we say this life is worth living, this one is not worth living?
Yeah.
And there was a study. There's even there's talk now of having infant euthanasia here in Canada, and they have it in Belgium and the Netherlands. And there was a study way back. Gosh, I can't remember the year, but it was in a journal called Acta Pediatrica. And in Belgium, they found that that only 81% of the neonatal euthanasias that were carried out were the parents consulted. So that 1 in 5 of those babies that the healthcare team decided that they didn't deserve to live, they never even asked the parents.
This is a published study?
Yeah, Acta Pediatrica. If you
Acta Pediatrica. I need to see that because
European one.
I find that really hard to believe.
Well, it's published. I can you send me. You got my email. Send me an email and I'll get you the reference. But it was a long time ago. But they found that there were, like, they talked to the parents 81% of the time, and so there wasn't a question of whether the family would like to take the baby home and love the baby for as long as possible or do what they could. It was the team that decided that this baby wasn't worth resuscitating or caring for, or they actually did an intentional termination of this baby's life.
Okay.
So, I think that once we decide as a culture that death of any sort of any member of our human family is, quote unquote, an answer to a problem, then we have trouble. Abortion or euthanasia, there's a violence to it. We are taking a life. I was on a task force with our national palliative care group before the legislature came down, and I made a statement. I said, I'm not sure that in this little task force, I'm not so sure that very many doctors are going to really feel like killing their patients.
Yeah.
And he came back one of the people came back at me and said, "Whoa, that's very inflammatory language."
Yeah.
And I said, "Well, okay, I want to play nice in the sandbox here. What should I have said?" And he said, "Well, you can say, take the life of a patient."
Okay. Yeah. Like the censorship of like just using words.
Just like that. And I don't want some poor lady to suffer on her own and do this. I've been on the board for these pregnancy care centers now for over 40 years. So I work on this at both ends of life. And we have the one here in Vancouver and Burnaby and Richmond. We have pregnancy care centers where women can come and get counseling. We don't refer for abortion, but we don't shame people. We don't show nasty pictures. We don't do any of that.
Yeah.
We give them options counseling. We have a maternity home where people who would be homeless without it are able to come and live there for up to a year after they have their baby. We have a safe house for women who are fleeing domestic violence, where they can come with their children and live there.
That sounds nice.
All of these kinds of things. So I put my money where my mouth is and my time where it is. And I have no interest in having, and everybody thinks, oh, it's these little teenage girls. No, most of the people we serve in this are people who are refugees, who are students from foreign countries, who don't have English as their first language, who have nowhere else to go, who have been working in entry-level jobs and now they're pregnant, and what are they going to be able to do? So we have a real calling to care.
Yeah.
That's what I feel about these things. And
that's really nice to hear. Like, I think if I'm being honest, I was a little bit nervous before having this interview with you, especially on the topic of abortion, because, as you may have seen, I recently posted about a patient that was treated for ectopic pregnancy, and I was really taken aback at how aggressive some of the comments were from like the pro-life people saying, that's not an abortion, but like by strict medical terms, that is an abortion.
Yeah, I know. It's the part of the problem is that the language that has been used against pro-life people is so extreme that people get touchy about it. Our pregnancy care center here, one of the ones here, the one here in Vancouver, has been vandalized 3 or 4 times with red paint splashed on it, poured through the letter slot. The graffiti company has taken it off carefully because they know that we're actually there to support women and to care for them. Nobody's forced to do anything. Nobody's forced to come through our door. We don't do, if we show pictures of normal fetal development, we don't show any, torn up babies or anything. And, I've had people that have, sorry, just going to turn off my phone here. I've had people that have said to me, well, you shouldn't be showing them pictures of normal fetal development. I said, look, I thought we were talking about informed consent. If somebody's going to change her mind after she sees what's normally going on in her body, then maybe abortion wasn't the right choice for her. She's going to find this out sooner or later. So I just have a real concern, and we do have a group and a sort of a counseling part for if people have had an abortion in the past and they're regretting that they can come and talk to we have licensed counselors they can come and talk to. We're part of the Rape Relief Victims Network, so if somebody's had that, they can come and talk to us and get some support. So we really do, we care about the women. We have all kinds of baby clothes and maternity clothes and diapers and all that kind of stuff that we do, and maternity classes and doulas that'll go with them when they're in labor, and all these kinds of things. It's comprehensive how they're cared for.
Yeah, like that sounds really compassionate and great. Actually, the reason that I actually posted that was actually speaking about the same classmate in medical school, because he had very, very extreme views even about abortion provided in these kind of extreme cases like ectopic pregnancies and stuff like that. And maybe it was because he wasn't that informed at that time? Like
I
at that
hope
period?
that was what it was. You know,
Yeah.
it's just, I don't. My own sister had an ectopic pregnancy as her first pregnancy.
Yeah.
And I there's not a way around that.
Yeah.
I don't think. And of course, a molar pregnancy. Well, that's not even really.
Yeah.
There's no fetus or anything
Yeah,
involved.
yeah.
But I think those things are really those are the minority things. Like I'm not putting people who you're being very reasonable about this. There are people who are really extreme on the other side about this too. We have 0 abortion law in Canada.
Yeah.
So technically, if you had a baby that was crowning and the mother said, I just want this baby dead, if you could find somebody to do it,
Yeah, that'd be
it's
crazy.
legal.
Yeah.
But so what is? I think that I'm not wanting to what I would like to see is a world where we care enough about each other that somebody who has an unintended pregnancy would get the support that she needs.
Yeah. I guess the counter argument though is that, as you know, because you're a mother, right?
Yeah.
How many children do you have?
I have 2.
2. Okay. So I have 1. And as a physician, I mean, like, I theoretically knew that the woman's body changes during pregnancy. But like when you actually see it yourself, you're like, oh my God, this is crazy. Like just like everything changes while they're pregnant. And as a physician, that doesn't come without risk. There is risk. It is known as the ultimate stress test for a woman, right?
Yeah.
Going through pregnancy. And so, like my general thoughts have been that it's a young woman who unintentionally became pregnant. They have this big journey ahead of them that is, not going to be like totally easy. And, I guess there's a lot of debate on like where life begins, whether it begins at conception or whether it begins at 22 weeks when you have a true viable fetus, or whether it begins when they actually exit the uterus, right? And
well, I don't think there's a debate about when it's alive. It's where do you assign personhood? Because personhood is what the law protects.
Yeah.
Okay.
Yeah, sure.
So personhood, if you say viability, that just, as one of the people said, who actually was an abortion advocate, said to me one time, well, that just means how much money do you want to spend? You push it back farther every year and there might even be a time where you could have an artificial womb. And so I don't think there's any debate that when you have a fertilized ovum, you have a unique human individual who is growing, and the only things that you're ever going to add to that person for the rest of his or her life is oxygen and food. You're not going to add any more genetic material unless there's some kind of gene therapy.
Yeah.
But for the most part, you're not really doing much. You're just, if you leave it alone, it's going to be a baby. Yeah. And so I think all this other stuff is really dancing on the head of a pin. And yes, a woman is taking on a lot. If you say, oh, I'm asking her to take on a lot. But like one of my colleagues once said, we're saying now that women can handle corporations and be in battle and everything, but they can't do the 9 months that their body was designed to do. What does that say? That's a low view of women to say that she can't handle the stress of a pregnancy.
Is that a feminist view or an anti-feminist view? I can't even really put
well,
my finger on it.
The feminist view is that we can be doctors, we can be lawyers, we can be corporate executives, we can do this. And then somehow we're going to, but we can't handle giving 9 months of our life so another being can come into the world.
But I think the feminist view is that they should have autonomy and be able to make decisions for themselves, right?
Yeah, except that you're not just making a decision for yourself. You're making a decision for the child that you're carrying within you. And most of the time, you knew that when you had intercourse with somebody that you had that there was a chance that you would get pregnant.
I mean, most people are just thinking about getting laid at that
Yeah,
point,
well,
right?
I don't care, but we don't say that with somebody who drinks and drives. We don't say, oh well, and kill somebody. We don't say, oh well, the person was just thinking about getting home after being drunk. We say you're responsible for what came out of that encounter that you had, and to me, there's something that, the other thing I've heard is, well, it's a parasite. It's not a parasite. It's a human being. And how can we come alongside people? So I worked in student health for a few years when I was first out of medical school, and I had quite a few young women who came in to talk to me. I was the only woman on the at the student health service where I was. And what I actually said to them is, they'd come in and they'd say to me, Dr. Cottle, I have a problem. I'm pregnant. And what I said, going back to something I said earlier, is, I said, you know what? You don't have a problem. You have a tragedy. Because finding out you're pregnant should be one of the most wonderful moments in a woman's life. But we can't, there's not a solution to this. There's absolutely nothing we can do right now to make you never pregnant again. So you need to decide what you're going to do about this.
Yeah.
So let's say you're engaged to be married. Well, if you get married a little bit early, there have been many people who have done that before.
Yeah.
If you decide you're going to be a single parent, there's lots of people that have done that and it's not that it's going to be easy.
Yeah.
If you decide that you're going to give a child up for adoption, that's not easy either, but there's lots of different ways that one can go about doing that these days. And if you decide to have an abortion, at this point in time, it is going to be the quietest thing. It's going to be the thing that not as many people know about.
Yeah.
But you are the one that has to live with this the rest of your life. And I'm not telling you not to do that. I'm just saying don't pay a lot of attention to what your parents are saying, what your boyfriend says. You are the one who has to live with the decisions that you make.
Yeah.
And we don't have a way. Abortion doesn't make you never pregnant.
Yep.
It doesn't do that. You have a tragedy. You have an opportunity to choose how you respond to that tragedy in your life, and what you're going to learn, what the trajectory of your life is going to be. It will be different if you're a single parent than if you get married and have this relationship, or if you give the child for adoption, whatever. You have all of these different options, but you need to think about them really carefully, because despite what it says in the media, there are quite a number of people who regret having had an abortion. And you need to decide whether that is something that would be hard for you. And the other thing you need to decide is if you need somebody to help you talk to your loved ones about this, because oftentimes what you fear they're going to say is way different from what they do say. And so we don't want you to be alone in the midst of this or do whatever. But this idea that somehow abortion is something that fixes this that's just not true. It doesn't fix it. You can never be never pregnant again.
Yeah.
You have to think about these things, and that's kind of what we do at the crisis pregnancy centers. Is we help them. We say, this is not an emergency. You have time to think about this. I mean, not forever, but you have at least a few days to think about this, talk to people, and think about what you're going to be glad you did 10 years from now.
Yeah. Okay. I mean, that sounds quite reasonable. I am all for supporting people, especially during such a critical period in their life, right?
Yeah.
Yeah, I guess my views still always come back to supporting a patient based on their own values. And I just feel I've been thinking about this throughout our entire conversation. You your views and the way that you practice medicine is so clearly guided by your Christian faith, right? And for me, like, I abandoned my Christian faith and now I subscribe to just like straight patient-centered care, which what I believe is patient-centered
Yeah.
care, right? And I just wonder, like, it seems to be quite a big divide and a big difference between, quote unquote, old school doctors who are in the older generation compared to doctors that are in my generation who have graduated and are practicing in the last 15 or so years. And like, have you noticed that yourself?
I would say I still have quite a bit in common with my Christian colleagues.
Okay.
That I have quite a number who I'm still in touch with and that would believe the way that I believe about a lot of these issues. I think, I don't think it's fair to say that the old school people are not concerned about patient-centered care. And I think we have been. I think about the people in my class, and many of them, did the best they could with the resources that they had, and we didn't have like we didn't have the internet available to us just at that moment to do a search on different things. You had to go to conferences and read the magazines and do all those things. So there probably was less. There were less informed studies, that people would do, and they would likely have relied on pattern recognition within their own practice to say, well, usually this has been helpful to people that have this particular thing, and would do that. But I think people who have a real heart for caring for their patients have been the same for a long time. And I think, going right back to Hippocrates, with who was not Christian, obviously, from BC, about talking about not giving to deadly medicine to anyone if asked, not giving a pessary to cause an abortion, just respecting life at a certain level and understanding that life was a good in and of itself, if we talk about the societal goods, and that protecting it was really important, and that he wouldn't train anybody until it wasn't something you did at the end of his training. You had to affirm the Hippocratic Oath before he would train you, and his group of physicians would train you. So it's that idea. And before Hippocrates, the person who was the healer was the person who also had the drugs that could kill you. And if the guy down the street paid more money to the witch doctor or whatever, then you never knew what you were getting. But Hippocrates' followers had said they weren't going to do that. And there were other things within the Hippocratic Oath about not taking advantage of people and not doing things that you weren't trained to do, and all of those kinds of things that showed that there was a deep respect for the fellow members of the human family. And I like that terminology better than the sanctity of life.
So what would you say about your physician colleagues who don't subscribe to the same ideology? Say the palliative care doctors who do actually administer MAID, or the physicians who do administer abortions or DNCs just for...
How do I feel about them?
Yeah.
Well, to be honest, I probably have a better feeling about them than they have about me in some ways, although that's maybe not fair to give my palliative care
You think
colleague.
that they would really dislike you?
No, I think they might. I think some of the people who, the palliative care colleagues would not. I think some of the people who are more militant on the pro-abortion side of things would be very upset about me being on the board for a crisis pregnancy center, which they call fake clinics, when we do pregnancy tests and that's it. We're not doing anything, and that I think there's a lot of kind of misunderstanding about me being judgmental. I'm not judging them. You know, I understand, like I said to you before, I understand how people could think that it was a good thing for that poor woman to have MAID when she came in. I just think that there are better ways of dealing with suffering than eliminating the sufferer. I think there are better ways of dealing with an unplanned pregnancy than eliminating the baby or fetus or embryo, whatever you want to call it at that stage.
Okay.
You know, if you go in at 13 weeks with a pregnancy that you want, and they put the Doppler on and they say, this is your baby's heart. But, you know, I'm not allowed to say that, that it's a baby until later. So I think that the
censorship is crazy.
Yeah.
Yeah.
You know, I think we can be better than just saying, go your way and be warmed, to use a biblical thing. I think we can learn to care for each other.
How do you broach the conversations though with like physicians who disagree with you, like particularly physician palliative care doctors who do administer MAID? Because there are some.
Yeah, there are.
Yeah,
there are some who do, and I've been on committees with them and everything, and it's I have commended them for the good work that they have done, but I can't go on that part of the journey with them. Some of them have done some very good work in palliative care, and have done, worked with people that are living on the margins and doing other things like that. But I can't go along with that. Now, interestingly, when MAID first came in, one of my colleagues who's been a big proponent of this in the past, I said to him, what if the reason the person is coming to you is because he's poor and he's living on the street and he just doesn't want to live anymore? And he said to me, well, that wouldn't qualify. So I wouldn't assess it. I wouldn't do it. So of course that started happening. And I said, well, what about this?
Is that I can't believe that's happening. People are getting MAID for homelessness?
Well, not complete homelessness, but for example, there was a woman here in BC, in Vancouver, who had multiple multiple chemical sensitivities, and she couldn't get supportive housing where she was going to be free of the chemicals and everything. And they said, well, you could have MAID. So she got MAID instead of getting supportive housing. And there was a man in Toronto who, a lot of people who are homeless qualify just fine for MAID because they've got all these other, you've seen them, you know the comorbidities they have, and nobody's going to do that.
Those would be like typically track 2, right?
Yeah, some of them, but some of them have been deemed by some of the people who have been more aggressive about this of saying, oh, well, you've got, I know of one specific case where a colleague of mine was asked by the wife of this patient to go to see this gentleman who was living in a not so great care home. He had cerebral palsy, I think, and he was living in this care home because he needed the care, but it was a double room, and he just wanted to die. And one of the more aggressive palliative care, well, not one of the more aggressive MAID doctors went to see him, and his wife called my friend and said, can you go and see my husband? I think he's gonna get this. So I went to see him, and he said, well, you're not dying, you're just here. And he said, well, this doctor told him that he was in bed all the time, and there was a potential for him to get bed sores. He didn't have them yet. Yeah. And the bed sores could get infected. Yeah. And if he got infected bed sores, then and he didn't take treatment, his death would be reasonably foreseeable. Yeah. So this doctor was willing to do MAID on the basis of that, and actually ended up doing it. So
I mean, like I feel like the gray track 2 is definitely like a really,
Yeah.
really big gray zone,
Yeah.
and like
No, I
think,
get that.
yeah, I think my personal perspective is like it
Yeah.
needs to be evaluated on a case to case basis, and like I with these kinds of cases that you're telling me about, I don't have all the facts, so I
Yeah.
wouldn't be able to weigh in on it. But
Yeah.
yeah, like
Well,
it's just,
anyway, I went to this colleague afterwards and I said, look, this is what's been happening. And his response, I said, some of these people, the main reason they're asking for this is not because of the underlying disease. It's because they're homeless. It's because they're lonely, whatever. And he said, that's not my job. Yeah. He says, I'm just there to see whether they qualify. And now it's gone one step further. So now those of us who are saying, if people are having MAID mainly because of the social determinants of disease that are happening, and we say that's not good enough for us as a culture, that just because you're underhoused or all these other things that you should be getting MAID. We're being told by these same folks, well, you're the paternalistic one. Who are you to say that just because somebody's living on the street and that's part of the reason that he wants to have MAID and he qualifies, that he shouldn't be able to have it? So, to me, it's completely gone upside down from that. But there's something that makes me very sad about that kind of rationalization that, well, if you qualify, it's okay. That I want us to be better than that. I want us to be a place where, if you end up pregnant, we come alongside you and we help you. If you are at the end of your life and you're feeling like your life isn't worth anything, you've got all this stuff going on, that we come alongside your family. We're there to tell you that you don't have to be beautiful or wonderful or physically able to help us or mentally even with us to do this, that we are going to care for you because you are a member of our human family and you matter to us. Yeah. And so that's where I come down on these things. And I understand, to be honest, Jeff, this is one place where my Christian faith comes in. I was a person in high school who was very passionate about social justice. Okay. And I could see myself being really passionate about these issues because I would see them maybe as social justice. So I graduated from high school in 1970, which was right at the end of the Vietnam War, right at the end of all the civil rights things, all of that going on. So, which shaped who I was really as a person. So I was passionate about this. You could probably tell I'm a bit of a little terrier. So I was passionate about those things. But when I became a Christian and the Holy Spirit got a hold of me, this is personal for me. I'm not saying it has to be for everybody. I began to see things through the lens of how Jesus would see them, and to have the same kind of lens that Mother Teresa has. When she sees a dying person, it's not like a piece of trash. Yeah. This is somebody that is a member of my family. I need to care for them. This is somebody made in the image of God. I need to care for them. And these colleagues of mine are the same. And I realized that I could be those other people without the intervention of the Spirit. I could be the people who are pushing for these things because I think that there's a social justice element to it. But I have had the Spirit come alongside me and say, look, yeah, there's a justice element in this, but that love is bigger, love is better, love is greater.
Great. Well, I think we'll call it there.
Okay.
Thanks so much for a great conversation. I learned a lot. It was very insightful, but thanks so much.
Okay, you're welcome. Yeah. You're welcome. Thanks for inviting me and not just blowing me off. This is an interesting young man. I'm going to DM him.
Yeah, great.